Dr. Annie Peters came aboard 5 years ago to build our Outcomes Research Foundation, and she did it. It's built. It's produced four annual reports.
That's three.
3 annual reports. Maybe I am tired. And they're available, and the centers are getting their individual reports. It's really something we're very proud of. If there is a lasting impact, frankly, I'll tell you this, that I'm able to help build in my career, it's going to be that. It's that. It's a foundation that does what is necessary to make this work the level of healthcare that it needs to be. So, Dr. Annie Peters.
Thanks, Marvin. Thanks, everyone. So yeah, I'm talking for about less than half an hour, and then we'll introduce the panel. But so if you don't know me, as Marvin said, I'm Annie Peters. I'm Director of Research and Education at NAATP, and I'm going to talk about data-driven leadership. One thing I've been kind of talking about with people this morning is I've been thinking about, how I'm going to talk about data-driven leadership, and I'm always someone who kind of tries to come from my heart when I talk, and that's one thing I always feel at this conference is, we have a lot of pomp and things and pretty things that a conference should have, but when I always get to talk to people one-on-one, like I did with Nick Hayes this morning, I did with a couple of the others of you, we talk about leading from the heart. And I do believe that I feel that a lot at this conference when I start talking to people. And I think even more so if you've been out around the hotel or out in the city. I live in Boulder, Colorado, and work at home and have been a bit isolated from the front lines of addiction for a while. And I was not last night and the night before. Had to call 911 to get help for someone. Had to saw some stuff that I don't usually see. I hear about in meetings, and I used to see a lot at treatment, but it reminded me why we're all here and why it is important that we lead from our hearts and we get as many people help as we can. So I'm just grateful to you all and for listening to then how do we use data? I think I looked up what does it mean to use data in healthcare, and it said using data to inform decisions, improve patient care, reduce costs, and improve workflows. So, which is really all the challenges I think we've been talking about at this conference. We've had topics on all of these issues, and those are the things I always thought as I got into this field. I need to do from the heart. Is use my heart and my training to inform decisions, improve patient care, reduce costs, and improve workflows. And now, more and more, we live in a culture that is driven by data. And so somehow we have to figure out to be data-informed or data-driven, which means using data and our hearts and each other to drive change in a field that desperately needs it, and particularly now when we're struggling to figure out how we fund ongoing SUD care, even just saving people's lives, how we fund that. So how can data? What does that mean? And so as NAATP, as your national association, we need to model that. And so what that means, and what that means is combining the collective work, as data becomes more and more available, more and more prevalent, more and more in our lives every day, every moment of our day, especially with AI and things like that. How many people use ChatGPT this morning to answer a question? People also become more and more important. And our hearts become more and more important because that can't, at least not yet, be synthesized. So that's why we're here. And how do we, as NAATP, help each other and help this field become more data driven? And so we do that through FoRSE. So FoRSE is the NAATP Foundation for Recovery Science and Education, and many of you know about it. And our mission is to improve addiction treatment through science, technology, and education. So I know there's a number of you that came to the workshop yesterday and went through in detail the report. I have a couple slides in here about the report, just for those of you who didn't see it. I'm sorry if that's a little repetitive, but yeah. So just a brief, if you don't know what it is, FoRSE is a 501c3 nonprofit developed in 2020. We realized at that time, we knew that people needed help using their data to do better healthcare, better addiction healthcare. And so we said, well, there's a couple of things we need to do. We need to get more research out there to improve the field as a whole. And we need to get information, data insights to providers so that they can advocate for their programs from numbers. Our original thing that we talked about all the time was when you're asked, what's your success rate, which we're asked a lot, how do we answer that question with numbers, with a chart, with data, not just from our hearts, which is what we're used to and what is most meaningful to me, but that doesn't often change laws and that doesn't change minds a lot of times. So we developed, part of what we do is the Addiction Treatment Outcomes Program, which isn't just treatment, actually. It's treatment and recovery support. It's a way for any provider of any service, SUD service, to use their data to benchmark, to compare what they do against others in the field, and to do so confidentially. So our goal is not to rank you or anything like that, or put your data out there. It's to help you make sense of your own data and also to see our data as a field and look at what it means in a time when we may not be seeing a lot of SUD data publicly for a while, with some of that being defunded. So this is the system we have to collect it. We have a lot of the vendors here in the exhibit hall who are EMRs, who are mobile apps, and we're really grateful to those that support this program and allow their customers, and they did it for free, which is what's amazing. They said, you know what, this is so important that we're going to do the development work to allow our customers to connect to this database, and we're not going to charge them, and we're not going to charge you. So they did that. And now we have this large FoRSE de-identified data repository, de-identified because we don't want you to worry about your patient's data. We do two things with that: reports to you, back to you and to the public, and then research evidence. So I'm going to just briefly talk about both of those. We'll start with research. These are 4 universities that we have partnered in various ways. I believe we have a couple of University of Michigans in here. Do we have? There we go. Hi, University of Michigan. This is really important because use of data requires the experts who know how to use data and how to get data into the literature, it is the research literature that ultimately informs practice and moves it forward as a whole. And so we're grateful to these. We've published with Montclair State University, and we're working on finding grants with Boston University. We're working on a publication with Texas Tech, and we just received a grant with the University of Michigan that is about improving research capacity, particularly at residential addiction treatment centers. So if that is something that appeals to you, if you have a residential program and you say, you know what, I want to be involved in improving our research capacity, our ability to do research, let us know, because we are doing focus groups and trainings, and that's what we want to do, and essentially bring evidence-based practice into addiction treatment, residential addiction treatment, in a way that hasn't been done before, and really demonstrate the power of a residential program for that study. Just want to mention briefly that of the research that we've done so far, it's primarily had a health equity focus, and I'm proud of that. We published the first item there, homonegativity, bi-negativity, and trans-negativity among substance use practitioners, revealing that in our workforce we do have those things, and we need to have safe environments for everyone to recover. And so we need to be aware of those biases and work through those. Employee perceptions, we found that has been submitted for publications. We found there that women, BIPOC folks, LGBTQ folks, don't perceive that we're as far ahead in health equity as leadership thinks they are. So that's important, is that when you ask everyone at an organization, overall, it looks like we're committed. We want everyone to have access to care. But when you ask folks that have traditionally been marginalized, they feel less strongly about where we are with that. So, and finally, a manuscript in preparation with Texas Tech is about, perhaps unfortunately, not surprisingly, particularly in residential care, Black folks tend to leave treatment against medical advice more than white. So, just we want to keep those things in mind because that's important for our future. And then to the other piece that FoRSE does, which is the reporting to the participating providers and to the public. We have 3 public reports, the third of which there is out now. It is available through your app. And this is a way to communicate to the world the value of what we do. And I have just a couple of slides in here just to show you the power of our data collectively. And so how do we do data-driven leadership through this? Through this slide, we see, you know what, there's a profound thing that happens to people in treatment. 42% reduction overall in depression and anxiety symptoms during the course of care. And that's over all types of care. That's an average. But people come in as we know, extremely anxious and depressed, and we have an impact on that. It is a significant change, a significant difference. Recovery capital is at the bottom. I didn't show the graph because it's a little less understandable, but it is in the report. But overall, there was a significant increase in recovery capital, 18.4% increase in recovery capital as measured by the BARC-10, which means we are also, for the BARC-10, that's a lot. We are also improving people's recovery capital during care. We are building their internal and their external resources that help them to experience long-term recovery. And that's the impact we're having on people, as well as reducing symptoms. We're improving, things like hope and family, and ability to have friends and things like that. So this is something we decided to look at this year as our data gets cleaner and gets more robust from the partnership with all of you. We get to dive a little deeper and we find some things that are really important. Like, for example, against medical advice discharge, why does that happen? It happens for a lot of reasons. We know that. And some of the things that are most obvious, unfortunately, the first one there on the top left is age, that our age group 18 to 25 has a significantly higher risk of AMA, of leaving treatment against medical advice before the treatment team thinks they are ready to move into recovery outside of treatment setting. Another group is, as we might have guessed, an opioid use disorder. If people identify opioid use disorder as a primary issue for them, they have significantly more chance to leave treatment again. So what this means is, to be a data-driven leader, it means that we need to have specific interventions for young people and young adults and for opioid users. And if we don't, then we need to implement those. And there are evidence-based practices that are available for both of those. So when you get your own report, make sure you look at that or ask me, and can you look at our data and see if we have that as well? Because we want you to know, I do need to implement some sort of practice to reduce AMAs among this particular group. And then finally, the last one in the slide there is an interesting finding of residential versus outpatient. I am a little biased from my heart because I went to residential treatment, went to outpatient as well. Both were helpful. But I was very engaged in my residential program. I did not leave early, and I think that happens for a lot of people. In fact, to the extent that in our data overall, there's over you're 5 times more likely to leave against medical advice if you're in an outpatient program. And we've seen this, but now we realize that there's something engaging about residential treatment, not just keeping them there because they're not against their will usually. So there's one good thing about residential is it engages people enough to keep them there. And then the last finding here Couple other things we looked at. We wanted to see, again, we know that some of the big factors of what makes good treatment is how long a person is engaged in treatment of any type. And we found that patients who spend more than 30 days in treatment had a 23% reduction in relapse risk, which we know intuitively, and we say, you stay longer, you get well, and now we get to see in our data a very significant finding. As well as now we have a number for it, is patients who leave treatment against medical advice have an 85%, almost 86% higher risk of relapse. And I understand relapse is not relevant for everyone, particularly harm reduction programs, but for those of us who measure that concept, that's an important finding, that if people are leaving, their risk of staying off the drugs they came in for help with is their risk of going back to that is much higher. And finally, before I introduce the panel, just summarizing that the two areas that FoRSE works on is the reporting, which is our reports to you all, to the public, and to those of you who participate, and then our research partnerships. So if you're not, so let's do this. If you are if you work at a FoRSE data site, can you raise your hand? Excellent. Oh, this is so good. This is awesome. Yeah. So that means these folks contribute data and receive reports. If you work at a FoRSE technology partner, can you raise your hand? Yes. And they're in the front row. Yeah. Front rows. Awesome. Thank you. Yes. If you are a FoRSE donor, if you've donated anything at all, including your time, raise your hand. Awesome. And then all of the above, let's raise our hands. Yeah. So not to shame those who don't have their hands up, but there's many ways to help. Yeah, it kind of did, but no, there's many ways to help. So keep your eye out for our research initiatives. If you want to join FoRSE, I'll be in the FoRSE room most of the day. And I'm happy to talk to you. There's our email right there. And this is how we become better at data-driven leadership, and heart-driven leadership together is we look at our data and we use it to become better providers. So thank you. And I will now, thanks. Sure.